Dr. Dirkley. It's my pleasure to welcome Dr. Jorge Mineiro. He's a professor of orthopedics and traumatology at the University Hospital Santa Maria, head of the orthopedic department and spine unit, Hospital CUF Descobertas, head of the pediatric spine unit, Hospital da Estefania, all in Lisbon, Portugal. Welcome.
That's very kind. Thank you very much for having me in your program, which is a fantastic tool for all of us orthopedic surgeons.
My pleasure. The more people that can benefit, the even better. Makes me happy. Now,
Indeed.
Today we're going to talk about a very new non-fusion technique for surgery for adolescent idiopathic scoliosis. Now, many of my viewers are used to the term vertebral body tethering, VBT, which approaches the spine from the anterior approach. Now, we're going to discuss posterior vertebral pedicular tethering today. I was wondering if you can talk a little bit about the origin of this particular technique from your point of view, because there's quite a family history involved as well, going back to your father.
That's correct. Well, and let me tell you, I'm a great believer in this technique, although obviously this is not a panacea for every scoliosis, unfortunately. And I hope that by the end of this talk, that people will understand a little bit why are we so positive about it. And I will start off, hang on, let me see. Well, as we know, there are people over the years, spine surgeons, in particular the ones that are dedicated to pediatric scoliosis. Over the years, we have been trying to find some sort of solution in order to prevent and refrain us from fusing the spine. And obviously fusing the spine in this young adolescence age has some drawbacks. As we all know, I mean, the chest and the chest development by the age of 10 is only up to 50% of their normal size, adult size. So the age that we have to operate on these children, we can compromise the development of the chest, which I think is a major drawback, as we all know. Therefore, I mean, there have been developed over the last couple of years different techniques, which are basically they are either distraction-based, growth-guided, or tension-based. And the one I'm going to be talking about is the spinal tether, which I think are the one that I'm more focused in this talk. Well, we have to go back and see that this is a technique based on the Uter-Volkmann principle. And this goes back to 1950s, when pediatric orthopedic surgeons, to correct lower limb deformities, they would put staples on the growth plates, both on the convex side where the growth was faster, in order to stop and restrict the growth on that side of the joint and stimulate the growth on the inside, on the concavity. Well, it took a couple of years for it to be popularized and around the spine. And when we look at it, when it sounds to be such a recent development, but there was an orthopedic surgeon who was a genius, a Polish orthopedic surgeon called Adam Gruka, that, as you can see, back in 1958, he operated on a couple of patients in the United States and published this article in JBJS. And 2 years before, he presented this technique in France and published in La Revue de Chirurgie Orthopédique et Traumatologie. Well, when we look at the picture from his original papers, and I got acquainted with this technique by some of the patients that my father operated on. He was a close friend of Adam Gruka, but my father died when I was in my 4th year of medical school. But I'm talking about this new technique at that stage. Well, and when you look at the original paper from the JBJS, you see exactly, well, the springs on the concavity of the scoliosis and how it corrected. And not only that, but he also developed the device on the concavity by distracting the concavity, as we can see on these pictures on the right. And also, the instinct, he used the combination of both. So concavity tension-based and this concavity distraction-based, which is amazing because we're talking about 1958. Well, my father died many years ago, and I have to undo his study. And when I went through the pictures of his study, I came across these beautiful pictures of his scoliosis correcting by using the Gruca springs. And you've got here, obviously, probably a lanky 1C, and then the hooks of the springs were on the transverse processes on the convex side, obviously. And here you've got a double curve, and here again, you've got a more severe, probably lanky 3 double curve, and we can see how it corrected. Well, so based on this, we thought that this sounded ideal, but the feature that I was so surprised, going through all his data, there were no lateral views. And when we go back, then we think that at that stage operating, and even Paul Harrington, who was also from the same generation and a good friend of his, they were very concerned about the AP, the coronal view. And I think Paul Harrington's draw the attention that orthopedic surgeons dedicated to this cause, they should also look at the lateral view in order to preserve some of the balance. And so I thought to myself, well, if it does work in the coronal place, in the coronal plane, well, why doesn't it work on the lateral view as well, the sagittal? So that's the reason why I decided to adapt that into the reality, but instead of using the Gruca springs, using screws and a tether that we have been using nowadays. So based on this, I'll take you along. This is a girl that, interesting enough, mom came to me about 2 years ago. This is the oldest case that I have. Mom came to me and having failed conservative treatment with a brace, she says, "Doctor, I know there are some new techniques around that you don't have to fuse the spine." And I said, "Well, I've got one technique for your girl. Would you accept to be the first one and be a trial?" Yes, go ahead. So this is a girl, a 14-year-old girl that refused to use the brace, progressive thoracolumbar curve, Adams positive and the scoliometer about 10 degrees, no leg length discrepancy, no neurology, no other abnormalities on clinical examination, and menarche at 13. Well, here is the X-ray that you can see, and obviously she was a lanky 5C, and on the lateral view, normal MRI, and under GA, obviously it would reduce to 20 degrees. And the funny thing is that you see that there is a thoracolumbar kyphosis with a very straight thoracic kyphosis and 47 degrees of Cobb angle that was gradually getting worse. So she had seen other orthopedic surgeons that said, well, there is an indication for surgery, taking into account that she was a Sanders 3 or 4 or a Reeser 2. Well, so what the alternative was, either brace or a posterior fusion or this growth modulation. So we decided to propose to the mother to do this posterior tethered pedicular technique. And it's such a beautiful, simple procedure. As you can see, you approach usually the midline, as we will explain. You just go one finger breadth towards the side, and between the multifidus and the spinalis, you open the fascia and you palpate the base of the transverse process. So you can see this immediately post-op. One of the features that I was so surprised is that without any derotation, you can see that the height of the rib hump is gradually decreasing. But here you only apply tension, and immediately post-op you can see that it corrected. So this is 1 year after. You look at the top end and you look at this, whoops, that's looking a little bit awkward. It's quite tilting towards the opposite side. Well, I say, well, wait, let us see. This is probably the growth. We'll wait a little longer. And the girl said, "Doctor, but the waist is changing the opposite side." And so I said, well, let us repeat the x-rays. And what we can see is throughout these 10 months, she was gradually overcorrecting. So the decision here was, again, well, should I give it up? Should I fuse the girl, or should I persist with the growth modulation? I've explained that to the mother, and I said, well, my feeling is that I think I should cut the tether, and I think this will correct. So immediately post tether correction, she beautifully realigned the spine. And now this is the picture of the girl, and this is the longest. But one of the features it's so beautiful is that without derotation, we can see that along the growth, she was a Nash probably grade 3 plus at the beginning, and she gradually derotated with no maneuvers whatsoever. So just by using the stent on the convex side and obviously stimulating the growth of the growth plates, it does only increase the growth vertically, but it also decreases rotationally. So it de-rotates the spine, which I think is amazing with the growth. And that's the reason that at the last follow-up, which was in December, the girl looks rather nice with a very straight spine. And so this was the procedure that I'm now performing. Well, when the surgical procedure, as you can see, this is a very short procedure. It takes between 1 hour and 2 hours. I never put more than 6 or 7 vertebrae. And for me, it's a contraindication if it's a long sweeping curve. The blood loss is about 50 cc's to 100. Hospital stay between 3 or 4 days, and it's much easier to control pain post-op. And I always do this and their SSEPs and MEPs and motor evoked potentials. So you can see between the two, we open the fascia. With fingertips, I palpate the base of the transverse process. This is rather avascular. There's no blood in here. And obviously then I use the image intensifier because being a less invasive procedure, you don't have the whole figure of the vertebra in order to find out the rotation of each of the vertebrae. So I use the image intensifier for putting the screws. And then one of the important steps in this is that you cannot use the tether to reduce the scoliosis because the tethers are not strong enough for that purpose. So you would have to put and reduce by hand. And once it is reduced, then you put the tether according to the rules. So you don't use the tether to correct the deformity. Otherwise, you may loosen the screws. And that's one of the complications that the recent papers show up. So you reduce by hand and then put the tether. So that's the technique.
Excellent. I have about 5 questions already.
Yeah, sure. Please go ahead.
All right. Now, when you derotate the spine with leverage on the screws, what stops the spine from just going back to the scoliotic position on the surgical table?
Well, one of the important things that also when I look at the papers that were published afterwards, only one in San Francisco, the other one in Lyon, none of them assess flexibility. And the flexibility for me is essential, as was also pointed out by Ahmet Alanay. It has to be at least 50% flexible. So when you reduce it, and they are reasonably flexible, by just putting the tether, it doesn't keep the same position, but at least it reduces a great amount. And that's the only technique. You put the highest tension, 400 newtons at the apex of the curve, and then the 2 subsequent levels on each side, 300s, and then either usually 200 at the end. So you're decreasing the tension from the apex of the curve outwards. And I believe if they are not flexible, the problem is the moment you take your hand off, it will go back to the same position. And then you need to put more strength on the tether, and they would either break or the screws will work loose in this younger population.
So to summarize, basically, you need at least a 50% flexibility. And once you derotate with the screws, it'll hold enough that you don't have to use maximum tension on the tethers.
Absolutely. They always go back a little bit. So
yes.
I expect to have on the table about 10, 20 degrees. And when you stand up, they go to 20, 30.
Very good. Now, the screws you use for the pedicles, are they different than the vertebral body tethering screws?
I'm afraid not, and that's one of the drawbacks because they are not low profile, and some of these children are skinny and thin, and therefore I'm waiting for somebody to pick it up and try to develop a lower profile screw head, because I think it is essential.
Now, when you use the tethers, because with vertebral body tethering, some surgeons are using, because of the tether rupture rates, are using double tethers, etc. Is this for single tether use that you're currently using?
Yes, only single tether. Well, but it's interesting what you mentioned. If you look at the paper from René Castellin and Torbish, which was published in 23, well, they had about 40 patients with more than 2 years, and using double tether. But then 90% of the tethers did break. Well, but hang on, because when you look at the age of the patients, they were all Sanders 6 and 7. So, and they don't accept flexibility. So people are moving away from the growth modulation for using this as a mobile device instrumentation in almost adult spines. So it doesn't work. So they only correct 50%, as René Castellin pointed out. Why? Because they have very little remaining growth. So you cannot expect growth modulation. And this technique should be for growth modulation. Sanders 3, 4, and eventually 5. 6 and 7 are not appropriate for this technique. They don't correct on one hand, and they break, even with double tethers, as was shown by René and Torbish.
Absolutely. Have you, with your published paper and afterwards as well, have you had any tether ruptures with this particular technique?
Well, we haven't looked for it. My indications for looking for it is that if between the two screw heads increases the space, and for that is the only one that I've been looking for, and so far we haven't found one. But I believe because they are flexible and because I limit the number of degrees up to 60, from 45 to 60.
It's interesting because do you think there's, when you go with this posterior approach, do you think there, and of course, combined with the flexibility of the spine of the patient, at least 50%, do you think there's less tether tension from the posterior approach versus the traditional vertebral body anterior approach of the location-wise, I guess?
Yeah, well, if you have an overlook at if you look, for instance, at the paper from Alice Boranici from Germany, and she followed 152 tethers, and about 55% of the tethers did break, and most of them at the second 6 months, and then the other 30, about the other half after 1 year. Well, but I think the reason why is that if people are using these things for sustaining and keeping the reduction, well, they will fail. The beauty of this technique at the stage that it is done is that the maximum tension, as it is at the apex procedure, from then onwards, the concave side will gradually increase in height, and therefore the tension on the tether will gradually decrease. And that's what I'm working in by an engineer lab here and trying to find it out. But that's my only excuse. If it grows and if it corrects the deformity, the tension on the tether will not increase, but will gradually decrease and become rather loose.
Follow-up question. Now, with growth modulation, that's in the, it's in the vertebra, but with the speed of the adolescent growth spurt, it could be Dr. René Castellin, but it could be Dr. Peter Newton. Can't remember the papers, but there were a couple indicating that there was more change in the disc in terms of disc wedging during the adolescent growth spurt, right? Do you feel that by squaring off the discs with the correction from this particular technique, does that have more impact on maintaining the curve correction until growth modulation catches up to the vertebral bodies?
Well, I mean, to tell you the truth, I don't think so. And I'll tell you why. Because, I mean, if you look at the different growth plates in the disc, and obviously the posterior elements as well, well, when you put the pedicle screws, the tension, the maximum tension is right at the corner of the posterolateral corner. And if you put the screws in the front, it puts more tension on the disc than putting, it's like an external fixator putting on the back. There's some mobility in the front. On the opposite, if you put the tension right over the vertebral bodies, you've got little space for that to happen. So I think the damage and the tension from this particular technique is much less than if you apply the screws in the vertebral body, which are right over the disc. So I'm looking at that as well here by engineering modelings, obviously 3D, but I believe the reason why is that we're looking at the pressure and at development of the discs. And also what we're looking at is that the modulation of the vertebral body, which is gradually improving. So the wedge shape that the vertebra's deformed apex have when we start, with the growth modulation, this wedge shape gradually decreases. So the ratio between the lateral and the medial side of the vertebral body are gradually coming together. And that's one of the things that we're looking at the moment and is improving at 1 year follow-up in our cases.
Well, it's pretty fascinating because it's interesting to see disc vertebral relationship and all that. Now, another question I had was with the first case you indicated with the overcorrection at the upper thoracic curve, how do you know in terms of which levels to cut the tether in terms of reducing the overcorrection? I'm sure it's a bit of an art.
It's an eyeballing, to tell you the truth. Usually I go from the sort of mid. Usually I put 6 to 7, and I always go between between 2 and 3 screws that I cut the tether, because even if the deformity recurs a little bit, I don't mind. I mean, I'm not a perfectionist in the way that I want a spine absolutely straight. No, I want it to be much better at the end, because children with 20 degrees residual curve, they do a normal life. So I'm not very much, even if they go back and they lose a little bit of correction, well, fair enough.
No, I 100% agree, because to me, functionality in terms of
absolutely
the health of the spine trumps
anything that can
correction.
Preserve functional motion. I think it's so valuable, and that's what I'm aiming for, to show slowly.
I understand, because I know some surgeons are very aggressive in terms of wanting perfect corrections, right? And and they'll add too many levels, but it's to me, functionality is the way to go.
I was once like that, but I've lost it. Yes, and that goes the other thing. The beauty about selective fusions, and I explained to the parent, listen, I'm not going for a straight spine. I rather prefer to have a residual deformity that has the spine, the thoracic spine is fused, and a residual deformity in the lumbar spine that your child can cope with and lead a normal life, running, playing, having children, everything, then to fuse the whole spine, both curves, and have an absolutely straight spine, but at a high price of degeneration and bad quality of life.
Now, since you touched on selective thoracic fusion, have you ever thought of doing a hybrid with this particular technique for double curves?
Right. Well, let me tell you, in this meeting that we ran last month, it was discussed because of the paper from Mohammad Diab from San Francisco. Mohammad had 14 cases with a 2-year follow-up, fused the spine froze the spine on the thoracic spine, and then tether in the lumbar spine. And he had a very good reduction, but he had a 50% complication rate. And why? because there's no flexibility tested, and all these cases, 10% of the cases, 10 cases out of their 14 cases were research 0. But if you look at Sanders, research 0 go from Sanders 1 to Sanders 4. So if most of there are Sanders 4, well, it is understandable that probably didn't go as well as they expected. And you know that some Sanders 5 sometimes are still 0 in research. So, I mean, I know that one of the big drawbacks is maturity scoring is so difficult because this is an ongoing process. So to absolutely separate the different stages sometimes is very difficult. And for me, adjusting the surgical correction with the estimated growth remaining and dependent on so many other factors, that for me is the most difficult task at the present moment.
Understood. All right. Thank you so much. I'll let you continue.
Right. Well, let me show you here. I mean, this is the technique, as I said, but the indications, as you can see for me at the moment, is age 10 to 14, 40 to 60 degrees, 50% correctable, and obviously no more than 6 or 8 vertebrae. Well, the series that we are now reviewing, these 6 cases that I presented in the original paper, they have now reached 1 year. And one of the main concerns that I remember when I've shown Larry Lanke about this technique is, George, this is a wonderful procedure. The technique, it bleeds very little, and I used that approach in the past. But my concern is that they may grow and develop hyperlordoses. Well, when you look at the paper from Pierre Steinera published in the 60s, he shows that the lordoses, that this normal lordoses, go from -10 to +25. And when you look here at 1 year follow-up, the upper lordoses is exactly the same. So my explanation, although I've got no evidence to show that, is again, because the maximum tension is at the apex procedure. From then onwards, with the growth of the concavity, it loosens up. Therefore, the pillar that usually would expect to create hyperlordosis gradually decreases. So that's the reason that up to 1 year, we've got no one single case of these 6 or 7 cases that we've got that has developed into hyperkyphosis. And as you can see, I mean, the distal lordosis remains pretty much the same, which has also been pointed out by other surgeons. As far as the spinal growth is concerned, they do growth. But as I mentioned, one of the difficulties I have, if you've got a curved spine, and if you straighten the curve, the 2 endpoints will gradually move away from each other. Well, if you have this in a child that is growing, and if these 2 endpoints are moving away from each other, is this growth or is it just mechanical correction of the deformity? There's no way we have been able to separate. And that was one of the challenges here with the lab to discredit. They can very easily, in one single procedure for the treatment of scoliosis, when we do all the maneuvers and derotation in one single procedure, they can separate. They've grown so much and they've derotated so much. But when you have to bring growth into action, then it's a very different kettle of fish in order to separate what is growth, what is mechanical correction of the deformity. So, and we can see the cob angle has improved dramatically, although there's a bias in here because the girl that overcorrected is here. But even if you get to the end of growth with 16, 20 degrees, I'm so happy because they started off between 40 and 50.
Absolutely.
Yeah.
Absolutely. Yep.
So the reason why I base this, that I believe this is only suitable for thoracolumbar and lumbar, is based, I remember when I started my residency in Oxford, we did a couple of Zilk procedures, and they looked so beautiful, and it did make sense. But when you look at the original papers from Alan Dwyer and Klaus Zilk, you see that this is very favorable for the thoracic region, but disaster results in the lumbar spine. And again, Zilk says exactly the same. The problem of kyphosis in the lumbar spine remained. And it wasn't until Kaneda described the cages in the front in order to create lordoses, and having one or double bar to create lumbar lordoses. So if there is such a nice evidence from the 60s and 70s that anterior instrumentations in the spine, you shorten the anterior column, how can you expect this to create lordoses? So that's the reason why I believe, and looking at the literature, that doing that in the thoracic spine, I think it's a beautiful procedure. Although I do question if it is worth it, because selective fusion seem to give such a good result, and mobility from one or the other has been shown by one of the systematic reviews from China isn't that much different. So, and for me, the main drawback about AVBT in the thoracic spine is the mechanical complications. You have to open the chest of these children again. It's a major undertaking with a lot of risks. Besides, going from the back, you can do it under local anesthetic, and after 2 hours, they get up and go home. So even if I haven't had to do a final fusion, but if I have one to do, I go through the same midline incision, and instead of approaching the convex side, I'll go to the concave side and use a 6 millimeter cobalt chrome bar. So I think there's so many advantages of using this technique, but that's the reason why I believe I'm not very fond of the endothoracic spine, because of these selective fusions. And I've got several, and even if they are not 100% correct, they look so beautiful and they work so well. But the selective fusions for the 6C in my hands are a disaster, because they always remain with a bit of a rib hump, and the children are so disappointed because they never correct fully. So I've stopped selective fusions for the 6C curves. Well, and so just a bit of a summary, a strategy for spinal growth modulation. It preserves chest growth, it preserves spinal growth, as you can see, and it corrects the deformity. So I think, but you need to be beware of the technical restrictions. I think these are suitable for Cobb angle between 45 and 60. They need to be flexible in my hands. I think AVBT are suitable for the lanky one, but obviously when you go above T6 is a problem to place the screws appropriately. Posterior vertebral pedicle is suitable, as I've shown, for the lanky C. We've done 6C that we've discussed here, and the advice, it has corrected beautifully the lumbar curve, although the thoracic curve has not improved. So I do wonder if the indications for selective fusions should also be used for growth modulation, or, as I said, if you've got thoracic and lumbar spine, should you grow for more modulation alone or for a hybrid? That means fuse the thoracic spine and obviously growth modulation in the lumbar spine, because it does improve. So these are a little bit of the views. I don't know if you've got any other questions before showing you my summary and my ideas about this.
Yes, I do have some. Of course, I have questions. You know me.
Yeah, but go ahead.
Okay. Because we'd spoken a little while ago, and it's very fascinating because at that time when we spoke a couple months ago, you were excited about it, but it seems that you're even more excited now about the data you're getting back.
Well, the reason why is that because we're now following and writing up the paper about 1 year follow-up, and number of complications is so small, and most of them are improving, but not at the same speed. And I think this matching between the surgical correction and estimated growth is a major problem. Although Sanders is a beautiful technique, is a beautiful classification and score. And now we've got, as James Sanders showed in your program, the estimate of the progression of the scoliosis. But we need to tune that up for this growth modulation, and we're not quite yet there. However, I think that if you select your patients appropriately, this is a growth modulation. You cannot use this as a mobile instrumentation because it will fail. Using this in a standard 6 or 7, or using that as the French used it with a research sign. The mean research sign in the Sanders paper was 1.5. That was between 1 and 3. Well, they are so grown-ups. You cannot expect the growth to correct the deformity. And therefore, what happens? You put a lot of tension on the tether, and in the French paper, 20% of the screws became loose. Because obviously you're not correcting, you're not expecting the growth to correct, but you want to correct the deformity by putting the tension under too much force, and they fail. Either they break or the screws become loose. So, and I think for any technique that you do at the very beginning, you should be very restrictive in order to gain confidence and show this is a valuable tool and a good technique. And obviously, when we think about if it does work, well, look at, for instance, a neuromuscular. If they walk, instead of building the Eiffel Tower on the top of their pelvis, if they've got a mobile instrumentation that can walk much easy. So even if they don't correct fully, wouldn't that be a solution much easier? On one hand, so it opens a lot of an horizon of other alternatives. But to begin with, yeah, I think you need to stick to the rules, and my rules is that 45 to 60, the cob angle, 50% correctable, and the 5C lanky curves for the time being.
It's because I first heard about this technique with Dr. Diab when he was using the posterior tethering, and I thought it was pretty fascinating and out of the box thinking at that point. I wanted to bring up flexibility as well, because it seemed there have been a couple of papers regarding vertebral body tethering in terms of losing lateral flexibility. For instance, in a thoracic spine, even with single tethers, you lose around 78% flexibility. In the lumbar spine, it's about 50% flexibility with tethers, with AVVT. But with flexion extension and rotation, it's pretty well maintained. Have you noticed any reduction in flexibility in terms of different planes with this particular technique?
Right. Well, I do. But again, it varies a little bit between patient to patient. And the reason why is that for the ones that are very active, the decrease is much smaller. For the ones that are very sedentary, then obviously they are still very decreased, but they decrease about 50% of their motion. For the ones that play gymnastics and I think they probably lose it mainly in lateral tilt, about 20%. That's my guess, but we're just working on that. But I'm very cautious about X-raying, doing too many X-rays on these children, and that's one of the things that I'm very concerned with. But I do, in the clinic, I see that children that are very sedentary, they are probably about 50% less. But for the ones that are very mobile, they continue to do PE and play all different types of sports with much more mobile, indeed, than if it was a definitive posterior spinal fusion. But it is not a normal spine, obviously.
Of course. And, hamstring shortening,
Absolutely.
etc. And of course, with the kids that are much more active, their hips are much more flexible generally as well.
Indeed.
Another follow-up question I had is basically with flexibility again and growth. Since this procedure, and I really love the fact that if you have to cut tethers, it's a very simple procedure. You don't have to deflate lungs. You can just go from the back, look anesthetic. Once the child hits maturity, skeletal maturity, is it possible to also just cut the tethers to improve flexibility? What do you think about? I'm sure you've thought of that.
Well, but again, what I've just mentioned to you is exactly my principle. For instance, this girl that I've just shown you, Marta, I mean, Marta, she's got a spine that is so straight. I mean, the tethers are loose. Why should I go back and cut the tethers? Because they were tension when she had 7 degrees. But the moment she started increasing, they are loose. So I'm not concerned to go back and cut the tethers because the tethers are loose. And I've got, I don't know, I'm going to try to with ultrasound to see if the loosening or if there is a, how do you say, to see if there is any difference. But it's just early stages to find out with the ultrasound if we can recognize that the tether is loose. But for this girl, I'm not concerned because she plays everything, sports, tennis, and everything with no restriction. And so even if I'm sure it is loose, it's not tension.
And it just popped into my head. Now, with respect to growth modulation and exercise, do you feel with this is a question, do you feel with a child that's very active versus a child that's very sedentary, would there be, you think, more growth modulation in an active child versus a sedentary child?
Well, I believe it may. I believe it may because of this is a dynamic process. And obviously, by the movement, but a dynamic for two purposes. First of all, because the movement enhances, and I believe the movement increases the stimulation on the concave side, and obviously it varies a little bit. So it preserves growth on both sides at different speeds. And I think that if it was a very static, the result would be completely different. That's one thing. The other one is rotational. And I think rotation is very important for the derotation of the deformity, because if it was a static thing, a static instrumentation, I think this wouldn't stimulate so much the derotation. And I believe that preserving derotation is also stimulated by movement. So I'm a great believer that obviously this being a dynamic process is very important.
Okay. All right. Thanks so much for answering that.
All these are just based on, there's no clear evidence, it's based on the cases, and I'm looking at that. But the factor to introduce growth in these mathematic modulation systems is very confusing because the growth is not constant. Second, the growth is dependent on so many other factors that it's not only the skeleton, but the rest, hormones and many other things that are influencing growth. And obviously we cannot expect in just looking at the bone that they all react and they all behave in the same way, because they don't. Plus all the tissues are, how to say, all the flexibility, if they are more flexible or less flexible like we all are. So all these taking into account, that's the reason why we have great difficulty to tune up surgical correction and estimate the remaining growth at the end for the rest of the growth for these children.
Okay, thank you. Please continue.
Right. Well, I think that the things that I believe there are pros and cons. The pros about this vertebral tethering is that we bleed very little. There's very little bleeding. There's no or much less damage to the posterior spinal muscles. There progressive 3D correction, as I've shown in this case and has happened in most of the others. It does not compromise the chest and the spinal growth, which I think, remember, if these are children between 10 and 13 and 14, obviously the chest size is still growing. So the more we can help for them to have a normal rib cage, the better. it preserves spinal motion, a functional spinal motion. It may not be normal, indeed, I do agree, but it preserves spinal motion, which is much better than a posterior spinal fusion, which much less strain on the adjacent levels. So I think this is a major advantage as well. Because the vertebral posterior tethering is easy to access and solve the mechanical complications, as I've shown, and obviously it prevents the crankshaft. Well, what are the cons? Well, the cons is that on one hand, it is not suitable for every single scoliosis, adolescent scoliosis. Vertebral body tethering, it opens one or two cavities, which I think is a major undertaking. And looking at this paper, which I think came from Germany a few years ago, in 2021 or 22, where they've compared the AVPT anterior from chest, thoracolumbar, and lumbar. And when you look at the complications rate, although the lumbar ones were the ones that corrected more and more easily post-op, they had about 50% correction compared to about 8 or 9 in the thoracic spine. So again, I mean, doing VPT in the thoracolumbar and lumbar, it makes you wonder. It's not the ideal procedure for that type of deformity, in my own view. VPT is risky operations because mainly if you have to go back and correct something that is unexpected, because as I said, matching the growth and matching the correction is something that we're trying to tune up. And as Ahmed Alanai, who is the person that I know with the largest experience, even Ahmed that was in this meeting, he says, we haven't reached the stage where we can say absolutely be confident we just correct this and so much because this is a Sanders 3, 4, or 5. And we are still looking for that appropriate matching to decrease the number of mechanical failures. Patient selection, Sanders stage, is not ideal, but is the best one we have indeed, and that's the one I'm using. So when I look at these people using and publishing these cases based on research, I feel so sad and disappointed because it's very, I mean, it's very large. It's not a very accurate classification and scoring. AVPT, obviously, looking at different papers, comparing AVPT with PSI, well, about looking at the paper from Peter Newton, about 52% of their cases with AVPT were residual deformities less than 50 degrees. The mean was about 35 degrees, which I think is so disappointing for a child. And I have great difficulty to tell and expect parents to tell, well, you're going to decrease from 50 to 35 at the end of growth. They are not very happy. So I think that's one of the things that I think that I would rather prefer to go for posterior spinal fusion for the thoracics, and for the other ones, if I get them at the appropriate age, I will go for the posterior tether. AVPT with a significant percentage of residual curves, and the two-segment AVPT is a major undertaking that, based on this paper and based on all the others, if there is a chance of undercorrection or overcorrection, go back, open the belly, open the chest of these children for a surgical procedure that is somehow still experimental. I do not agree, and I refrain from doing it. So this will give you probably an overview. So in our series, we had two complicated mechanical complications, one overcorrection proximal, the other one distal, solved with minor procedures and a day surgery unit. It is possible that a portion of the mechanical complications might be attributable to the learning curve, as I've just mentioned, about this matching, and obviously can be lessened by optimizing patient selection and the surgical planning. However, I think if this is the cost for preserving growth, alignment, and motion in this immature abnormal spine, I think that it is probably worth the price. So just to finalize, what I would say is that vertebral tethering is a promising tension-based technique of growth modulation, and obviously for the treatment of just a selected group of AIS patients. Posterior vertebral pedicular tethering is ideal for the lanky 5C scoliosis. It induces the 3D regression of the deformity, which I think for me is so beautiful. AP, lateral, and axial, as I've shown. Well, it is a less invasive procedure, and mainly it is so easy to solve the mechanical complications. And even if I ever have one screw that is loose, by the same approach, almost on the local, we can sort it out and the patient goes home the same day. Treatment strategies are similar for the vertebral tethering anterior and posterior. And I do fully agree, and I've learned so much for Ahmet Al and I, test flexibility, and between 40 and 60 degrees maximum, that's the ones I use for this technique for this group of patients. As I've shown in this last follow-up that I'm just preparing the paper for publication, there's a much better balance of the sagittal profile of the whole spine, and with no hyperlordosis. So far, that was one of the main concerns, and I would agree that was reason for that. Well, IS for skeletal immature who wish to avoid fusion may benefit from vertebral tethering, and I think this should be explained to the parents and should be offered, taking into account and obviously showing them that this is a rather experimental technique, showing what is the evidence so far, but I think it's so beautiful and I think it helps a great deal. However, obviously we need larger series, longer follow-ups in order to be able to validate this.
Excellent presentation, Dr. Mineiro. I'm really excited about this procedure. Looking forward to your new paper coming out. Thanks so much for giving us your time and your expertise.
Well, it was a joy. Thank you for having me. And as I said, you've got such a wonderful program with this. I've learned so much from it. I hope that this will bring some clarification and to many of this business about this posterior pedicular tethering, which I'm a great believer that it's so beautiful, it can help so many people, but please don't use it as a mobile instrumentation for people that are at the end of growth. No, this is a growth modulation. So use it at the appropriate time and you will see that patients will benefit.
Excellent. Okay, thank you so much again and have a terrific day.
Thank you so much for having me. Thank you.